And really quickly, what kinds of things can we do to prevent diabetic nephropathy? It's always going to be glycemic control. And that's because, remember early we talked about how much of this is stemming from that glucose toxicity, right? We want to be able to decrease that in order to decrease all of the complications that are coming from that, right? We want to decrease blood pressure. This is actually, a primary, not just in that it's a very important, but also one of the first steps in prevention of CKD. Having high blood pressure accelerates the progression of diabetic nephropathy a lot. It's actually crazy what a big difference it can make. A very, very small decrease in your blood pressure, like a sustained decrease, will actually decrease your risk of CKD a lot. We want to decrease proteinuria, so we might give the patient an ACE inhibitor or an ARB. Maybe might put the patient on protein restriction, again with the hyperlipidemia. That's pretty self-explanatory. And then smoking cessation. I would say smoking cessation is right up there with hypertension or decreasing hypertension in terms of, the big causes or the big risk factors. Whether you have CKD with or without diabetes, smoking cessation is something that needs to be discussed with the patient. It actually increases their risk of microalbuminemia, and it causes the progression from diabetes with poor control to chronic kidney disease twice as fast. It'll happen twice as fast with smoking. So it's definitely something we want to discuss with our patients. And as I've said before, the answer is always smoking. We always include smoking and alcohol and things that we need to cut back on. They cause so much damage in so many levels of our body. Treatment for neuropathic pain is often a lot of adjunct therapy. So they might use a tricyclic and some gabapentin, and then breakthrough opioids or what have you. Like I said before, neuropathic pain is excruciating. So, sometimes they get to the point where we just do anything to make the pain stop. Some of these are really good options and they work really, really well. Let's start with the tricyclic. So these are probably, hopefully you already know, they're used to treat depression. It's really funny. Most of the time when I see tricyclics prescribed, they are for their off-label uses. I think they're used for neuropathic pain and insomnia more than they are for depression. I think they work better for those things than depression. So what does a tricyclic do? It decreases or inhibits the reuptake of serotonin and norepinephrine in that synaptic cleft, and that means you have more of it left in your system, and that actually will decrease pain transmission. Again, there's a video on nociception and pain and how norepinephrine and serotonin play a role in that you can watch. For now, it's good enough just to know that they're believed to play a role in the transmission of pain through the spinal cord, an inhibitory effect on pain transmission through peripheral and central nervous systems is what we're doing here with these tricyclics. Again, it's an off-label use. Adverse effects. Interestingly enough, tricyclic antidepressants are anticholinergics. Cholinergic is the word we use to describe any system that uses acetylcholine. And the main one that we've studied in nursing school would be your parasympathetic nervous system. And so when we are working against a parasympathetic nervous system response, we are going to get a sympathetic nervous system response. This is how I think about it. And so whenever I see an anticholinergic that I know is working against the parasympathetic nervous system, I know it's going to have a bunch of sympathetic nervous system responses, like it's a fight or flight. So like increased heart rate, urinary retention, dry mouth, peristalsis like constipation and decreased peristalsis. blurred vision. So all of the things that are happening to get your body ready to fight or flight, to shunt your blood to the vital organs, to your brain and your heart, all of those things that are going on in a sympathetic nervous response. Again, you can check that out in a different video. That's what's going to happen when you take an anticholinergic. This one actually is fairly potent. I actually did try this for my neuropathic pain. My heart rate went through the roof and the dry mouth was like almost unbearable. It was really hard to talk. Everyone doesn't have those strong symptoms, but some people do. So if you run into trouble, just remember that it's an anticholinergic, and that should give you 10 or 15 symptoms just off the top of your head. It does cause, or there's a risk of orthostatic hypotension. There's extrapyramidal effects, as there are with many antipsychotics. You know what? I'll talk about them when I talk about mental health, but they're kind of like tardive dyskinesia, almost like Parkinson's, like shaking and stuff like that. They do cause lethargy and sedation. In fact, they are one of the other off-label uses other than neuropathic pain is insomnia. There is a high risk of suicidal thoughts at the very beginning, so it's a transient risk. So when you put someone on tricyclics, especially, you would probably try not to put someone who had a severe history of suicidal ideation, but especially if they did, you'd be watching them very carefully for the first 3 to 6 weeks. It does, like almost every other antidepressant, cause weight gain and have sexual side effects. So those are just kind of like the main things. If you come across, it's never ever shown up on a test for me, but SSRIs and tricyclics and a lot of antipsychotics and whatever, they need to not be taken with MAOI inhibitors. That's just an older kind of antidepressant. We don't see it a whole lot anymore. It's used to treat, usually when people have failed at all of these other kind of medications. So yeah, stay away from those. If they've had a recent MI or heart failure, again, a suicidal ideation. So if I were you and I were studying for this test that is focused on diabetes and diabetic complications, I would not memorize more than it's used for, like it's supposed to be an antidepressant. This is an off-label. I'd memorize it has anticholinergic side effects and then a risk of suicidal ideation. Those are like the main things. I wouldn't worry about anything else. Oh, sorry. And also that it doesn't kick in right away. It takes 2 to 6 weeks, which is very, very common for antidepressants. Another thing that we would use for neuropathic pain would be an anticonvulsant. And so the two big ones, two main ones, gabapentin and pregabalin, or Neurontin and Lyrica. So GABA is this kind of neurotransmitter that inhibits certain brain activity. Of course, the exact mechanism is unknown. Actually kind of helps us because we don't have to memorize it. But, it's involved in some kind of modulation, inhibiting the transmission of noxious stimuli, which pain would be, and it may affect pain indirectly through the effect on mood and sleep. I mean, sure, you can kind of keep it in the back of your mind, but if you don't have it in the back of your mind going into a test, it's okay. There's more important things to ask. Adjunct treatment is a prophylaxis of partial seizures. It's an anticonvulsant. That's its purpose. So a lot of people are given it for seizure prophylaxis. And again, neuropathic pain is an off-label. Adverse effects would be, your main ones. There aren't a lot, to be honest. Maybe confusion, depression, short-term nausea. I've never seen anyone have any serious complications from taking one of these. And if you've been in clinical or been practicing, I think you probably have some experience with these. They may have a drug allergy or hypersensitivity, could be angioedemic or anaphylactic, but again, it's something I've never seen either. Again, the only really important thing I would worry about here again is this increased suicidal risk. These are things we want to, and here's something that's, I mean, it's really important. Neuropathic pain has one of the highest suicide rates for, in terms of like medical causes, right? Like where people are just so in so much pain or what have you that they consider suicide. Neuropathic pain is incredibly painful, and knowing that these medications can increase suicidal ideation is really important in a population where they are at higher risk than an average person for suicide. So it's a good thing to know. Other medications we might use, SSRIs, so these selective serotonin reuptake inhibitors, similar to the tricyclics for this, in that they keep that serotonin in the system and hopefully will have an effect on the pain that way. It will also have the added effect of increasing serotonin for mental health issues, which is good. Opioids are used selectively, right? A lot of like the older tests will say, they might say morphine, or I had a test a while ago that said Demerol on it, and I'm like, we haven't used Demerol in like 15 years. So hydromorphone is really your big opioid that would be given for this kind of pain. Obviously, it's not something we want someone on long term, but sometimes there aren't really a lot of options. And then your capsaicin cream. You know, it's made from chili peppers. You have to put it on 3 to 4 times daily. Use gloves. That's kind of something that I've seen show up on a test. But again, it showed up on a pharmacology specific test. What is important to know about capsaicin cream is that when you start using it, there is an increase in symptoms. And so it's very normal to have an increase in symptoms for a couple of days and then have pain relief a couple of weeks later. So if a patient asks, it's normal. This is something, you know, if the patient's allergic to hot peppers because it is made out of chili peppers, we don't want to give it. Again, just think about what you would, I mean, you wouldn't put chili peppers near your eyes or open broken skin. That would be very painful. And again, it's got that transient increase in pain and burning when you first start taking it, and that's normal. So we need to make sure to educate patients regarding that.